Okay, good afternoon, everyone who has logged in today for this wonderful program. I am Raja Reddy here, Head of Marketing and Medical from Servier India. Uh, Before we actually enter into today's program, I would like to share a brief about the company, and that would be the only company slides you will see in this entire program. But before even I begin in, I would like to thank IPA, Manjiri Gharat, Madam Manjiri Gharat, because the idea was possible to execute thanks to her support in extending all possible support to see that this program can become a reality with the interest that pharmacists in India should be updated with the latest medical information. So now coming to Servier, some of you may know, many of you may not know. It's an international pharmaceutical company which is governed by a non-profit foundation. It's one of its kind, a 5 billion euro company, which is governed by a non-profit. Dr. Servier, who was our founder, the company belonged to him. It is a private limited company. He believed that money which is earned from pharmaceutical business should not belong to anyone except those who are in the field of medicine, patients, people in supply chain, and the employees. That is the reason why he ensured when he was passing away that the company, none of his children inherit his wealth. So that is the reason why he ensured that it is governed by a non-profit foundation. So some of you may wonder, so what's so great about a non-profit foundation? So basically, when you're a non-profit foundation, you're not obliged to deliver value for the shareholders. When I mean shareholders, I'm speaking about stock markets. Once you do not have that obligation of not delivering value, economic returns to shareholders, then you can pursue research questions, pursue medical questions based on patients' needs, doctors' needs. Because respect is one of the most important criteria for Servier. We treat more than 100 million patients are using Servier medicines every day. Servier is a leader in cardiology and second in Europe, fifth worldwide. What you will observe, because we are a non-profit foundation, 25% of our total revenue is invested in R&D. I'll give you, if you're wondering how is it so different, the best pharma company in the world invests anywhere up to 10% of its net profit in R&D, whereas Servier invests 25% of total revenue into R&D. So at the end of the day, there is nobody who's going to get money out of the profit earned by Servier. Everything is plowed back into research or paid as salaries to employees, which there is a cap. So what does Serdia? Serdia, the first three letters are the name of Dr. Jack Servier, and the last three letters of India. That's how it is Serdia, although it is Servier India. First, we support brands produced in India. Even before the Make in India program, Servier of our drugs are produced in India. And one more very important thing, I presented this for many years now continuously. There is no Chinese API. Because you will be surprised to know 70% of the bulk drug in India comes from China. So that states our over-reliance in China, which we are trying to reduce.
Audio is yes.
I'm sorry, I lost connectivity. So I'll share my screen again. So there are no South Asia specific molecules, which means basically, if a drug is introduced in India, I'll give you a very simple example. Take a drug like, for example, Damicron XR60, which is available at 12
Hello. Yes.
Hello, Sami. I think Mr. Reddy has connectivity issues. Hello.
Yes. All right. We can move forward.
Shall we go ahead? Hello, Sami. Shall I go ahead?
One second.
Yeah. This always happens,
Yeah.
especially it's raining.
Right.
Yeah, so we can
Actually,
understand.
Mr. Raja Reddy has some internet connection issues.
Yeah.
So what we will do now is, that was a message from Servia's side that we are with IPA and in this endeavor to share information and for the continuing medical information education of pharmacists across India. So this is a 3-day course, and we will hope to see you all across the 3 days at 3 p.m. for till today, tomorrow, and the day after tomorrow. And I will at this point hand over to Ms. Manjari. I think she's the chairperson of IPA. What we can do is so over to you, Ms. Manjari.
Yeah, thank you. Thank you, Sami. Thank you, Mr. Raja Reddy, and thank you, Mr. Sami Mukadam. And I'm very, very glad to have this collaboration with Servia for the second course. We already had first course for the pharmacist in last month, and now we are in the advanced course starting today for 3 days. A very warm welcome to all those pharmacists, hospital pharmacists, clinical pharmacists, and the community pharmacists who have joined us today from Indian. So greetings from Indian Pharmaceutical Association, and I extend my warm welcome and thank you very much to all the pharmacists, all the academicians, all the students, anybody from supply chain, so all the fellow pharmacists and the non-pharmacy teams who have joined us. Thank you very much for joining us for this advanced course. And so some of you might have attended the last course and some of you are already IPA members and some of you are not members, but you are aware or you're familiar with IPA. But let's run through the major features of IPA. So IPA stands for, as I said, Indian Pharmaceutical Association. It is one of the oldest, it is the oldest pharmacy association in India, established in 1939 in Banaras Hindu University. It works all across India through its trade branches and the local branches. And it has the divisions. We work through education division, industrial pharmacy division, regulatory division, community pharmacy division, which I head, and then the hospital pharmacy division. We also have very active IPA students forum. So IPA basically does all the activities through these divisions. So the 5 divisions and IPA students forum is active all throughout the year and all across India. IPA works closely with the different professional associations and as well as the government. We work with WHO, FIP, which is International Pharmaceutical Federation, Federation of Asian Pharmaceutical Association, Commonwealth Pharmacist Association, American Association of Pharmaceutical Scientists. So we work with all these organizations for different projects, different activities, as well as we work, as I said, all across India with the different pharmacy colleges, State Pharmacy Council of India, and more importantly, we work with the government on the policy matters. IPA has been since beginning member of the Drug Technical Advisory Body, which is the highest body which gives advice to the government on the drug policy matters. And we are also with the Ministry of Health and Family Welfare in the National TB Control Program Committee. There are many advocacy issues which IPA take up for the pharmacy profession. And if you visit our website, ipapharma.org, on the homepage, you will see different icons. One of the important ones is advocacy. So there are many issues in the pharmacy profession, be it a community pharmacy or the hospital pharmacy or industry, education. We have plenty of issues and there is a lot of scope to improve our profession. So whenever we come across any burning issues, IPA writes letters to the government, IPA talks to the government, holds meetings, and that is all summarized here on the advocacy. So you can go ahead and have a look at the advocacy letters. One of the most interesting one and important, the letter which we sent in April, rather in March, to Mr. Honorable Prime Minister Narendra Modi to include the pharmacist in the special package of medical insurance. So when the COVID started, the medical insurance package was declared by the Honorable Prime Minister but for the frontline workers. But pharmacists were not included. So IPA wrote a letter. So you can see many of the advocacy letters. We have several publications. Pharma Times is our official print publication, monthly magazine. And we have a research journal, that is Indian Journal of Pharmaceutical Sciences. And then we have various periodicals and books published. So IPA CPD Times is one of the most useful resource for the practicing pharmacist. It is a bi-monthly e-bulletin free of charge. And all the previous issues you can find on ipapharma.org under publications. This bulletin gives you all the ready-to-use information. It's like a patient counseling tools, consumer dialogue, drug information, pharmacy practice in other countries. So you get total overview and ready-to-use information. Then we have interesting resource produced for all the pharmacists, and that is the community pharmacy practice across the globe. Around the globe, part 1, which covers the community pharmacy practice from 31 countries. So please visit ipapharma.org again under publications and you will find it. One of the milestone in the consumer education, IPA has a book for consumers, which is the first of its kind in the country, Responsible Use of Medicines, a Layman's Handbook. And that was published in year 2015 at the hands of Honorable Health Minister, Mr. Sri J.P. Netaji. So this is one of the important resource, again available free of charge on our IPA website. We have a ongoing campaign for awareness on responsible use of medicine. We call it as abbreviated CARM. And several posters are placed on the IPA website in different languages. You're free to use it. You're free to use it for the public awareness. We have established with the government the public-private partnership engaging the community pharmacist in the National TB Control Program. So here the retail chemists are part of the National TB Control Program and act as dot provider. So this has been the historic happening in the pharmacy profession, as well as the first time entry of the pharmacist in any national health program. We celebrate National Pharmacy Week every year in the third week of November, and this is going to be the 54th National Pharmacy Week coming up in month of November now. And we have theme, each year we have a different theme, and this year we'll be having a theme around COVID. So we'll have many activities then. We facilitate the training of pharmacists abroad for their pharmacy practice exposure, so that when they come back, they can try to uplift the status of pharmacy practice in their own setup. So here are some examples. So we facilitated through the FIP's Pharma Bridge program. And these are the examples of the pharmacists who underwent such type of pharmacy practice exposure training in Scotland, in Sydney, Australia. So you can always approach us and we can help you to find a good placement through FIP Pharma Bridge. We also encourage the pharmacists to attend the international conferences. We may not be able to give the financial support, but we help you, we guide you, we show you the way so that you can attend the international conferences and get the bigger exposure. And so existence of the entire pharmacy profession is for the patient, and IPA keeps working for the public health by upgrading the pharmacy practice and by upgrading the pharmacy education. So again, on behalf of IPA, I welcome you all and thank you again to all of you for joining, and thank you, Servier, for this excellent program, and you have structured the program very well. So at the end, I would just like to say, let's be very proud of our profession, proud to be the pharmacist, and let's work together to take the profession to a higher level. And finally, it is all for the consumer. So let's improve the public health by our activities. And that's why exactly we are here today, for upgrading the knowledge of the pharmacist. As you will all agree that the pharmacist role has expanded in last few years, say last 2 to 3 decades, and the pharmacists are no more just the drug sellers, or they're not just the drug dispensers. So they have a much bigger role to play in public health, and it is important that their knowledge is always upgraded, their knowledge is always updated. So many of you must have done your D Pharm or B Pharm many years ago. So here is a time to refresh your knowledge from what you have learned in your colleges. Maybe some of it is forgotten. So we are here to upgrade your knowledge, and we have an excellent line of speakers all 3 days, and we have total 6 topics to cover in this advanced course for 3 days. So I'm sure you will, at the end of the program, at the end of the 3 days, I'm sure your knowledge will be enriched, and you will be definitely, you will get inspired to improve your practice in your day-to-day job. So again, I thank Servier for a very well-structured program of 3 days, which we call it as advanced pharmacy practice. And today, our first topic will be medication error, part 1, that is types and case studies, which will be taken by Mr. Heber. And the second session today will be medication error. Again, we'll be focusing mainly on drug-drug interactions. As you know, so many patients take several drugs altogether, polypharmacy. So we'll be talking about the drug interactions. And then there will be something very interesting, a quiz. And we'll be also conducting the quiz and announcing the winners of the quiz. And of course, then the question answer, and our speakers will be very happy to answer your questions. So this is the program that we have for today. And we have with us Mr. Heber Bright as the first speaker for today. And he's pharmacologist, M.Pharm Pharmacology, and he's clinical pharmacist and a lecturer at Christian Medical College and Hospital, Vellore in Tamil Nadu. He has worked with Kansas University Medical Center, and he has got the Model Junior Faculty Research Fellowship in 2018, and he's got many awards from the CMC, Chairman's Innovator Award for 2015 as well as 2014. He has got several publications in national and international journals. He has represented CMC in various conferences, and he has been a very active member and promoting the clinical pharmacy in India. So he's our first speaker. Thank you, Mr. Heber Bright, for joining with us. And
thank you.
Another speaker is from Chennai, and he's Dr. Krishnakumar. He's M.Pharm PhD, medical pharmacologist. He's professor and head at Department of Pharmacy Practice, CL Baid Mehta College of Pharmacy in Chennai. He has been working with many years. He has worked for many years with as a fellow, senior research fellow in ICMR. As you must have heard in COVID times, everyone knows about ICMR, Indian Council of Medical Research. So he has worked as senior research fellow with ICMR research labs in Jipmer, Pondicherry. He has also worked as pharmacologist in Regional Pharmacovigilance Center under CDSCO in Jipmer, Pondicherry. He has got more than 12 years of teaching and research experience, and he's got several publications, national and international. Many awards to his credit. One of the most notable one is the Upasla Prize for Young Scientist and Best Paper Presentation Award from Society of Pharmacovigilance in India. So very happy to have you, Dr. Krishnakumar. Thanks on behalf of IPA for joining us and accepting this invitation to be our speaker for this advanced scope. So thank you both the speakers, and I think we are ready to go for the medication errors. And I'm sure many of you are already having several examples of medication errors, or you might have come across medication errors. And there is nothing, I mean, to err is a human. So to make the mistake is a very human nature. But we'll see what are the types of medication errors and how we can prevent it and make our patients very safe. So over to you.
Can I go forward?
Yes, please. I can share your screen as well. You can see your presentation.
Yes, we can see it. You can just start the, yeah, fine. Thank you.
Good afternoon to all. It's a happy occasion. I thank Dr. Manjiri, Gharat for that nice introduction. I also thank IPA and Serdia for this wonderful opportunity and considering me as one of the resource persons for this beautiful course. So over the next 30 minutes, I'll be discussing about medication errors, its types and case studies. So these are the objectives for the next 30 minutes. So we are going to see what a medication error means, and we'll see the different methods of classifying the errors, and we'll discuss a few cases of medication errors that actually occurred in clinical practice. We'll also see or understand why continuing education programs are really important, especially for pharmacists to enhance medication safety. And also we'll see a few useful resources. So to start with, I'll give a small background for the session. Medication error is a very familiar term for all of us. Medication errors is one of the oldest prevailing medical problems that still remains unsolved. Even after several years of research, several technological advances, and besides all this, medication errors still exist. In huge percentage in all healthcare settings. Truly speaking, we do not know the number of medication errors. It all depends on different settings. For example, the number of medication errors that occur in India may not be the same as that of the US. The number of medication errors that occurs in the ICU may not be the same as that you see in a general medical ward, the number of medication errors that occurs in a tertiary care center may not be the same as you see in a primary care center or a community setting. So it all differs. It all depends on healthcare setting, the geographical location, and so we cannot say this is the number of errors that that prevails today. But for our rough understanding, I'll tell you some numbers from the recently published studies. One of the recently published meta-analysis, it has found that, medication errors occur in up to 50% of adults and 66% of children who get discharged from the hospital. This number is very huge, 50% of adults and 66% of children. 1 in 2 adults and more than 1 in 2 children, they end up getting medication errors when they get discharged from the hospital. So this can occur at any stage, while maybe at while prescribing a drug or while administering the drug, or while that can happen with the pharmacy as well. Relatively, when you compare all these stages where the errors occur, the errors that occurs with pharmacy is relatively lesser than other stages or other settings. I mean, dispensing errors are relatively lesser than prescribing and administration errors. So among the errors committed in the pharmacy, most often the error would be, wrong drug or a wrong strength or wrong dosage form, and several other types that follows up. So with this background, we'll move on. So medication error, we all know, but still we need to make sure that we know the proper definition, which is widely accepted around the world. So this definition has been widely accepted by WHO, NCC, MERP from the US, and also FDA. So it says that medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of a healthcare professional or a patient. So basically it means it's 100% preventable. A medication error is 100% preventable, but somehow it occurs, maybe because of my carelessness, maybe because I'm in a hurry, because sometimes I may not be aware of the drug, what I dispense or what I come across. So, sometimes the environment is not good enough for me to perform well. So there are many reasons why medication errors occur, but ultimately, they're all preventable, but somehow it occurs. There are several types of errors. We can classify errors into several types, but basically there are 4 important methods by which these errors are classified. I'll quickly go through every method. The first method is, it's based on the sequence of medication use, the stage in which the error occurs. For example, if a doctor prescribes a drug, writes a prescription, and if he commits a mistake while writing the prescription, that's called prescribing error. And when a nurse commits a mistake while administering the drug, that's called administration error. So if a pharmacist commits a mistake in the pharmacy while dispensing, that's called dispensing error. So this is one way of classifying the medication errors. So the second method is, it's all based on the actual type of errors. It'll look beyond the broad classification, like what type of error it is. Is it a wrong drug error, or is it a wrong dose? Is it a wrong route of administration? Is it a wrong frequency of dose? That kind of, getting into the errors. So there is another type of classification that's mainly, based on when the error occurs. Does it occurs while at the stage of planning the therapy, or while during executing the plans? For example, a nurse plans for a vancomycin injection, and she knows that it has to be infused over 1 hour, and she knows that. But unfortunately, while she ends up, infusing it over 30 minutes. Okay, that occurs in the executing phase. Not she knows well what has to be done, but ultimately the error occurred. So that's third way of method of classifying the errors. So there is another method that's based on the severity of the error. So they look into the severity. Is it a mild or moderate or severe? Did the error cause death, patient death, or sometimes is it only a potential error? So based on that, there are several categories: category A, B, C, D, E, and up to I. So this NCC MERP programs, they adopt this method of classification. So I personally, prefer the first method of classifying the medication errors, because I believe that many hospital settings, they adopt this method of classifying the errors. This is because this kind of classification will help us focus on a particular area where the error occurs. For example, a doctor writes a prescription in an inpatient ward in a medical chart, and somebody will come and transcribe the medicines into a prescription. So if we monitor too many errors occurring during the stage of transcribing, so we can focus on that particular group of people who involve themselves in transcribing, and we can implement some interventions to improve medication safety at that particular level. For example, if too many errors are noted at the point of dispensing, we can focus on pharmacists, and we can implement some interventions to improve medication safety in the pharmacy. So that's why I personally prefer this method of classification. Being working in a hospital, I prefer this method of classification. classification. But ultimately, all methods are very useful. Different people, different setups prefer different methods. For policymakers, they prefer a different method. Hospitals prefer a different method. While making decisions, they may have to prefer a different method of classification. So ultimately, all these methods of classifications are useful at some stage. So these are all, theoretical aspects of medication errors. So let me not spend much time on the theoretical aspects. I'll quickly go through some of the cases that actually occurred in the clinical practice. So, medication, one thing that we need to remember is medication errors are not new. It's always, it's always there. Since we started using the medicine, medication errors are always there. Some of the errors keep repeating. The one thing what we can do is we need to get updated ourselves, and we need to make aware of what's going on, what's happening in medication safety, and we need to make sure that we don't commit that mistakes in clinical practice. So that's why I'll highlight few issues that occurs very frequently, and similar errors occurs very frequently. So I'll quickly go through the cases. So this is the first case. This is a 49-year-old male patient. He underwent a stem cell transplant 3 months back. And later he developed, graft versus host disease, and it involves lung. And so he developed breathing difficulty, so he couldn't breathe properly. And so he was brought to the emergency department. So in the emergency department, it was noted that he had, low oxygen saturation. So he needed oxygen support. So he was immediately shifted to the ICU. So in the ICU, he was started on oxygen therapy, and also the doctor started him on a steroid called methylprednisolone at a dose of 60 mg intravenous once daily, along with few other medicines. So now the order is written in a prescription, and the prescription was sent to the pharmacy. Now see what happens in the pharmacy. Now the pharmacist received the prescription for methylprednisolone 60 milligram IV once daily. And he dispensed 2 depomedrol 40 milligrams per ml injection vials. Depomedrol is a methylprednisolone product that contains 40 milligram per ml of methylprednisolone. So he dispensed 2 vials because the patient needs 60 milligram. Okay, so far everything is good. The doctor prescribed the correct medicine. The pharmacist dispensed correct medicine. But let's see what went wrong here. If most of us may be aware of the mistake, but if you're not aware of what depomedrol means, you may also wonder what's wrong with this, case. So we need to understand that, depomedrol is not meant for intravenous administration. It's only meant for, other routes of administrations like subcutaneous, intramuscular, or intraarticular administration. So the word depot means it actually forms a depot under the skin when administered subcutaneously, or it forms a depot in the joints when given intraarticular, and slowly it releases the drug over a period of time. So generally, depot injections are not given daily. It has to be given, once weekly or once monthly, something like that. It's not meant for everyday injection. So in this case, the pharmacist somehow, he was not aware of the difference between depot products and the normal injection products. And he thought that it's same as other IV preparations, and he dispensed depomedrol injection. And it ultimately reached the patient, and the patient was given a couple of doses of depomedrol. So ultimately, fortunately, the mistake was found by a clinical pharmacist during the ward rounds, and the drug was changed to the correct one. So this is something very important, and we need to, should be very careful about this. Mix-ups with pharmaceutical formulations. You can also see in the picture both the depomedrol and solumedrol products look almost similar. With the same strength, 40 milligram, 40 milligram. There is it's high. It's likely that pharmacists can easily confuse between the products, and also we need to understand that depot is not meant for IV administration. There are many such depot products available in the market. For example, leuprorelin acetate, medroxyprogesterone acetate, testosterone. There are many such products, and even if you go through the literature, you can find many such errors that have been already reported. So this is one of the errors that keeps continuing. And we as a pharmacist, we need to be aware of this difference, and we need to make sure that we do not commit the mistakes, and also we should educate others on this particular issue. So we'll move on to the next case. This is a 63-year-old female patient. She's known case of hyperthyroidism. So she was scheduled for thyroidectomy, removal of glands. And the doctor advised the patient to take Lugol's iodine, that's potassium iodide, for a couple of weeks till the surgery. So she got the prescription from the doctor, and she went to a pharmacy to purchase the potassium iodide. So the dose was 0.2 ml, that's 4 drops, 3 times daily. So she received the drug from the pharmacy, and correct dose was dispensed. But unfortunately, the pharmacist forgot to counsel the patient on how to take the drug. So let's see what happened to this patient. She took the potassium iodide to home, and she wanted to take the first dose of potassium iodide, and correctly she planned to take 4 drops, but she didn't know how to take the drug. So she directly took the 4 drops into her mouth, and immediately she developed severe throat irritation and mouth irritation. Somehow she couldn't tolerate the irritation. Somehow she managed with plenty of fluids. She drank plenty of fluids, and she swished her mouth with plenty of fluids, and somehow she managed and got relief from the throat irritation she developed by taking the potassium iodide directly without dilution. So we should remember that potassium iodide is a concentrated solution. It has to be always diluted in milk or water before administration. So if you do not inform the patients, they do not know how to administer. An error occurred. So it's always very essential to advise the patient on how to take the medicines. This is not the only example. There are many other examples. And if you do not inform the patient of how to take bisphosphonates, for example, alendronate, the patients can develop, severe complications with gastrointestinal system. If you do not advise the patient on how to take anti-diabetic medicines, sometimes they can develop severe hypoglycemia. If you do not inform patients about, how to take a nitrate, for example, the patients can, result in therapeutic failure. So all these things can happen. So what we are supposed to do is make ourselves aware of how to administer that particular drug we are dispensing, and we should not forget to inform the patient or counsel the patient on how to take the drugs. Otherwise, we are missing the points, and finally, we may end up with committing an error. So I'll quickly move on to the next case. So this is a 63-year-old female patient, and she has uncontrolled diabetes. Her current medications include metformin, that's maximum dose, and glimepiride, that's also a maximum dose, and pioglitazone 30 milligram once daily. But still her blood sugars were not controlled. Her HbA1c was 9%. So the doctor planned to put her on insulin, and he planned to start her on basal insulin, that's insulin glargine, long-acting, and he prescribed 10 units daily initially. And she asked, the doctor asked the patient to come back after a couple of weeks to review the insulin dose. So the patient got an appointment with the diabetes educator, and she was taught how to administer the insulin and all. So she finally went and purchased the insulin. She went to the pharmacy. Now this is what happened in the pharmacy. We know that there are too many insulin formulations available in the market. I'm not sure if the prescription is not legible or not, but somehow the pharmacist misunderstood insulin glargine for insulin glulisine for insulin glargine, and he wrongly dispensed insulin glulisine to this patient. So unfortunately, this insulin glulisine is a short-acting insulin that's only meant for bolus. Insulin glargine on the other side is a long-acting basal insulin. So ultimately, the patient took the wrong drug, not being aware of what happened, and she started taking 10 units of insulin glulisine. But for the next visit, when she came back to the hospital, her blood sugars were still elevated, no control with insulin at all. So upon review, it was found that she was using a wrong insulin. That's when it was identified. So it was a look like errors. The drug names looks similar, but at the same time, sometimes this kind of errors occurs because we are not aware of different types of insulin. If you have the basic idea of short-acting insulins are not given alone as initial insulin therapy. Usually it's always combined with the basal insulin. So if we have an idea of all this, related information to insulin, we can enhance the medication safety. Unless and otherwise, we can't, and we keep committing errors. So that's one thing we need to focus on. Whatever drugs we dispense, we should try and get maximum information, maximum knowledge on that particular drug, so that we can practice a safe, pharmacy dispensing or clinical pharmacy or whatever we are involved in. So I'll quickly move on to the next case. So this is a 7-year-old boy, and he was diagnosed to have gastroesophageal reflux disease. The doctor advised to take lansoprazole 15 milligrams once daily in the morning. So what happened was the doctor, in the prescription while writing, instead of lansoprazole, he wrote the trade name of the drug, that's Prolans 15 milligram once daily for 2 weeks. So the patient took the prescription to the pharmacy, but the pharmacist was not aware of the diagnosis. He didn't know that the patient had gastroesophageal reflux disease. So he just looked at the trade name, and he picked up Prolans correctly from the pharmacy, and he dispensed Prolans tablets, 15 milligram once daily. But what happened was the boy returned home, started taking Prolans tablets, but his conditions and symptoms did not improve. Instead, he started developing increased sleepiness during the daytime. So the parents were much worried, and they brought back the boy to the hospital. When he came back to the hospital, the doctor was also confused, but upon reviewing the medication, it was found that the actual Prolans tablets that was held by the patient was not lansoprazole, but it contained olanzapine. This is a problem with, there are 2 Prolans products available in the market, both the products containing different pharmaceutical ingredient, one containing lansoprazole and one containing olanzapine. So we all know that olanzapine is an antipsychotic that might have induced increased sleepiness or somnolence in the patient. So this is something that we need to focus on always when a prescription comes with trade name on it. So we know that Medical Council of India, they urge the prescribers to go for generic names, but sometimes we see prescriptions with brand names or trade names. So in that case, we should be very careful of what we dispense. It's nothing wrong in talking to the patient. We can interrogate with the patient and find out the diagnosis, and we can try and match the drugs with the indication. If you see something that doesn't match with the diagnosis, it's worth talking to the doctor, or we can ask the patient to go back and meet the doctor again, make it for sure. So that's something that we can do as pharmacists. So I'll quickly go through the last case. So this is a 52-year-old male patient. So he was critically ill, and his sputum culture was positive for gram-negative bacteria. And so he had lung infection. So the doctor prescribed, based on the susceptibility test results, based on the results, he prescribed Colistin 2 million units twice daily as inhalation of nebulized solution. So a prescription was made for Colistin injection 2 million units twice daily. He prescribed Colistin injection because there is no nebulization solution available for Colistin in the market. So usually what is done is Colistin injection is used as nebulization. So that's why the doctor wrote Colistin injection 2 million units twice daily. So the pharmacist dispensed the correct medication. The medication was brought to the ICU. Let's see what happened in the ICU. So in the ICU, the nurse who administered the Colistin, she was used to Colistin, but she was not aware of the nebulization. Colistin is almost always used as injection or infusion. Okay, it's not often used as an inhalation. But sometimes for critically ill patients with lung infection, with susceptible bacterial infection, in that patients, they prefer, it's less common, but they prefer inhalation of colistin. So, but they use colistin injection for nebulization purpose. So this nurse was not aware, and she was very much used to colistin injection. So she failed to notice the route of administration. So when she looked at colistin, she thought it must be IV infusion, and she started giving IV infusion. So providentially, the error was spotted during the ward rounds of the clinical pharmacist, and the error was noted, and it was rectified after a couple of doses. Somehow it was rectified. So this is something we need to remember again, because this is an off-label route. The inhalation of colistin is not licensed, but it's an off-label route, but it is widely used in many countries. And you can see a lot of literature on nebulization of colistin. So we need to remember this. Sometimes some drugs are used off-label, but we need to be sure. Since a drug is very commonly used via a particular route of administration, that doesn't mean that it cannot be given by other route of administrations. So we need to make sure before administration very carefully about the off-label routes of administration. For example, some patients may need vancomycin orally. We do not have vancomycin tablets or oral preparations. So what they'll do is they'll order vancomycin injection, they'll dilute it in water, and they'll give it orally. Injections are used for oral administrations. Some tablets are available for both, can be used for both oral and vaginal administration. So we should be very careful about this route of administration, and we should properly counsel the patient, or during the ward rounds, we should be very careful that, the proper intended route of administration or whatever is being followed and obeyed. So by making sure all this, careful monitoring, we can very well enhance medication safety. So I'll stop with this case. To conclude, medication errors are very, very common in all the settings, irrespective of the geographical region, irrespective of healthcare settings. It's very common. And pharmacists play an important role in preventing medication errors. One reason, because this pharmacy is one of the last points where a patient come in contact with the healthcare professionals, maybe a outpatient or maybe a inpatient who gets discharged. Ultimately, they come to the pharmacy and they get the medicines, and that's the medicine that's going to cure the patient. So it's very important for us to make sure that, we need to take responsibility of medication safety. I need to make sure that I dispense appropriate medicines, correct medicines. I need to make sure that patient understands how to take these medicines. I need to make sure that the patient is okay with all the medicines that he or she is taking from the pharmacy. So that's how we can enhance medication safety. And also one other thing that we should do is we need to make ourselves aware of all these medication safety issues happening all around the world, by taking part in continuing pharmacy education programs and other education programs, so that we know what's happening, what kind of safety issues are happening around the world, and making sure that I know the errors happening, and I'll make sure that I do not commit such mistakes. So this is a pledge that we all should take to ensure medication safety. So I'll stop with this. These are two websites I would recommend or suggest you to go through. ISMP, that's Institute of Safe Medication Practices, and NCCMARP, that's US-based website, where you can get or avail a lot of resources for medication safety and regarding medication errors, and you can educate yourself. And there are a lot of literature available, open sources you can go through and make yourself aware of medication safety issues. So I'll stop with this. Thank you for patiently listening. I'll take questions at the end of the next session. Thank you.
Thank you very much, Mr. Heber. An excellent presentation and very interesting case studies you have given. And what you emphasize the importance of the continuing pharmaceutical education, and how the pharmacist is supposed to now take the responsibility for the patient safety. So the role expanded from just the drug dispenser or the drug seller. You emphasized it very well. And the case studies were real and eye-opener. So thank you very much for very, very interesting and very lucid presentation. And we move on
Thank
now
you.
to the presentation on drug interactions by Dr. Krishnakumar. I invite the next speaker, Dr. Krishnakumar.
Thank you, madam, for introducing me. Yeah, thank you so much.
Welcome.
So just I will directly I will go to my slides. So after that end, we can have a discussion. That will be better, I think so. Okay, very good evening, one and all. And first, I would like to thank Indian Pharmaceutical Association, IPA, for organizing this wonderful program, IPA Advanced Certificate course for all practicing pharmacists. And I would like to thank Serdia Pharma for actually they are organizing and contributing for their scientific side and bringing this opportunity for all the pharmacists to update their knowledge. And I would like to thank Dr. Raja Reddy and Sami and Kanmani, Miss Kanmani, for arranging this program, coordinating this program. And I would like to thank Dr. Manjiri Madam giving a brief introduction about me and as well as Heber. And thank you, Madam. And just we can go directly to the session because lack of time, actually already the time is running over, so we can go to the topic. Okay, and now I am presenting. This is part 2 in association with this medication error, the topic with medication error. So drug interactions. Most of the time we can see that medication error is a common term. Okay, but indirectly we can see that there is a medication error associated adverse drug reactions. Medication drug related events are most common like that. Most of the times we can able to read everywhere, right? But drug interaction is the silent culprit, and actually it will contribute much with this medication errors. So we can go through one by one. We are focusing on practicing pharmacist. So I prepared the slides for the practicing pharmacist most of the time, as well as for the academic pharmacist, and as well as clinical pharmacist. They know much about these drug interactions as well as medication errors. But anyway, they can update their knowledge. So what is medication drug interactions in medication error? There are 2 or more drugs can alter the effect of each other. So complete current medication records must be maintained for the patient to understand that what is the medication they are taking. Current medication records are very important because each patient they are going to take more than 3 medications. Actually, it is called as polypharmacy. Later we can discuss about that. Because once they have started using multiple medications, there are chances are there for one drug may be altered by action of the one drug is altered by the administration of the co-administration of the another drug, or maybe the availability of the drug may be changed. This is called as actually a exact drug interaction, drug interaction. But many problems occur because of the drug interactions that are actually not studied much well. So pharmacists always should aware about drug interactions. So this is actually I prepared. This chart is already available online. We can see that medication error, adverse drug reactions, adverse drug events. There are 2 types of adverse drug events. They classified as potential adverse drug events and as well as preventable, non-preventable adverse drug events. We can see that here drug interactions are present here along with medication error as well as preventable adverse drug reactions. Sometimes it is non-preventable adverse drug reactions, but it is also contributing for the most of the medication related misadventures. And today I'm going to present the contents or definition, example, risk factor, mechanism, outcome, and management. So definition. Okay, what is drug interaction? An interaction is said to occur when the effects of one drug altered by the co-administration of another drug, herbal medicine, food, maybe drink because of alcohol or otherwise any grapefruit juice or maybe another juice, and other environmental or chemical agents that may alter the drug action. So for example, we can see that first classifications, we can see that drug interactions can be classified into, it may be a drug interaction, drug-food interaction, drug-herbal interaction. And most of the time, adverse drug reactions due to drug interactions can occur. For example, drug-drug action, actually we can see that when warfarin is administered with aspirin or any other NSAIDs, the action of warfarin is actually altered and there is a chances for increased risk of bleeding and altered in INR, it is international normalized ratio. When we are going to measure, it is altered. So when it is administered with other NSAIDs or acetaminophen, definitely there is a chance of altered warfarin action. It increased warfarin action and leads to bleeding. It is called adverse drug reaction. The end is always adverse drug reaction due to these drug interactions. And drug food interactions, we can see the examples. Same classical example is warfarin with vitamin K rich foods. When we are going to take green vegetables like green leafy vegetables, there is vitamin K rich foods, and it leads to loss of anticoagulation effect due to vitamin K effect. Warfarin is actually, it acts by inhibiting the vitamin K reduction VKO-C1 pathway. So when we are going to take vitamin K rich foods, definitely the vitamin K level in our blood increased. That leads to lack of action of warfarin. And grapefruit juice, that when we are going to take with the statins, it leads to myopathy. And when common food drug interactions and common herbal drug interactions, we can see that ginger or garlic with anticoagulant, it increased risk of bleeding. This is the same zones what mostly in foreign countries they are used for multiple purpose. When they are going to take with the oral contraceptives, it leads to the failure of contraceptive effect. And capsicum with ACE inhibitors increase the drug absorption, and as well as the drug concentration will be increased, leads to severe adverse drug reactions. And here in adverse drug reactions with sildenafil and isosorbate mononitrate together, it causes hypotension. And potassium chloride with spironolactone, severe hyperkalemia, and theophylline and ciprofloxacin leads to toxicity, theophylline toxicity. The concentration of theophylline will be increased and leads to hypotension, hallucination, tachycardia, and seizure-related disorders. Why knowledge of drug interactions are important? It have been recognized for over 100 years. The important concept in the age of polypharmacy. Polypharmacy is nothing but when we are going to use more than 3 drugs, that leads to definite chances of drug interaction. Actually, polypharmacy is multiple drug usage. We can see that nowadays there are in prescriptions, we can see that several drugs they are prescribing. More than 5 or 6 drugs prescribed for each sign and symptom of the patient. And the drug interaction knowledge is very important to understand the cause of adverse drug reactions and to focus on safety and therapeutic effect of medications to prevent drug-related toxicity, or it is called as misadventure related to the drugs, and to ensure rational use of medications. So patients who are at risk of drug interactions, mostly we can see that patients with the disease conditions such as HIV infection, tubercular infection, and patients receiving immunosuppressant drugs for transplant, and patients, epilepsy patients, and diabetic patients in intensive care unit, patients undergoing complicated surgical procedures, patients who visits more than one prescriber. They will go to the doctor, and if they are not getting cured or the symptoms and signs are not settled down, they will go to another prescriber. And what the previous visit they won't disclose to this new prescriber, and they will take together both the medications. That leads to drug interactions. And patients with the hepatic and renal disease, this is called as drug disease interactions. Most of the time we can see that hepatic and renal failure patients, they need to adjust the dose, because when the drug is given, definitely if it is normal doses are very high for the patients with poor hepatic metabolism or renal elimination. So ultimately, the risk factors are, first one is polypharmacy, using more number of drugs. Second one is multiple prescriber. And the third one is multiple pharmacies. They will go and take OTC medicine from one pharmacy, and they will use their prescription for getting the medication in another pharmacy. That multiple pharmacies also leads to multiple drugs. They are going to take ultimately higher number of drugs, that leads to drug interaction. Next, genetic makeup. This is actually a person to person, the difference will be there, and this is called as inter-individual variability. This is mainly because of genetic variation. And next, a specific population like a female, elderly, obese, malnourished people, and critically ill patients. there are chances are more for drug interactions and the transplant recipient, because they are going to receive immunomodulators. So definitely their immunity level may be changed. And a specific illness like hepatic and renal diseases, renal dysfunction, and drugs with narrow therapeutic index drugs. In next slides, we can able to discuss it. We are going to discuss about this. And cyclosporine, digoxin, insulin, lithium are this class of drugs. And sometimes antidepressants and anticoagulants. So this is narrow therapy. First one is concentration dependent toxicity. So these drugs require careful attention when we are going to use in patients or when we are going to give to the patients. So we can see that concentration dependent toxicity is associated with the drugs having narrow therapeutic index. So we can see here digoxin, lithium, aminoglycoside, warfarin, and cytotoxic drugs are more concentration dependent toxicity drugs. So when we are going to take these drugs, it is accumulated in our blood and leads to toxicity. So when we are going to give these drugs, we have to monitor the concentration of these drugs. So when the concentration of the drugs is monitored, if it is excess, it is leading to toxicity. So we have to adjust the dose of these drugs, and as well as when we are going to give with co-administered with another drug, the drug may increase this narrow therapeutic index drug concentration in the blood. So we have to avoid such a combination. So prevent the toxicity of these particular medications. And the drug with the steep dose response curve, like such as verapamil, sulfonylureas, levodopa, this and all also interact with another class of drugs, and their concentration may be increased and causes toxicity. The patient dependent on therapeutic effect. So the patients receiving immunosuppressive drugs, glucocorticoids, oral contraceptive pills, anti-epileptics, anti-arrhythmic drugs, antipsychotics, and antiretroviral drugs, all are leads to there are drug interactions. Chances are therefore drug interactions. These patients who all are taking these medications are called as high vulnerable patients. Their chances are more for drug interactions. And saturable hepatic metabolism can be seen with phenytoin and theophylline. So the patients who all are receiving these drugs, when we are going to give a common drug, also causes drug interactions. Theophylline with ciprofloxacin causes theophylline toxicity. So what are the mechanism of drug interactions? So there are two types of mechanism broadly classified into pharmacokinetic and pharmacodynamic drug interactions. So pharmacokinetic drug interactions, here we can see that absorption, distribution, metabolism, and excretion already studied in pharmacology. So we are refreshing that same thing. So ADME here, pharmacokinetic profile responsible. The drug's pharmacokinetic profile is altered by another drug. That leads to drug interactions. And the next one is pharmacodynamic. Here we have pharmacodynamic interactions. Here we can see that the drug effect may be increased or may be stopped or may be altered. This is due to synergism, antagonism, or altered cellular transport mechanism. So pharmacokinetic drug interactions, already we discussed, they already said the same thing, absorption, distribution, and metabolism and excretion may be altered. Pharmacodynamic interactions, antagonism, synergism, as well as serotonin dependent interactions and drug or neurotransmitter uptake interactions can happen. So these all are the site of action of the drug, or maybe the one action of one drug is stopped or maybe altered or reduced by another drug. It is called as antagonism. If it is increased or enhanced by another drug, then it is called as synergism. So drug interactions with absorption, we can see that changes in gastrointestinal pH. Suppose the patient is going to take antacid or a histamine antagonist or maybe proton pump inhibitors. When they are going to take along with the ketoconazole, the effect may be reduced. Ketoconazole absorption may be reduced. So it is very difficult. The ketoconazole antifungal activity won't be there. And the drugs interacting with the another agents and causes complex, or it is called as chelation. So tetracycline or quinolone antibiotics interact with the calcium, magnesium, or aluminum containing antacids and forms complex, and the absorption of tetracycline or quinolone may be reduced. Charcoal or kaolin or anionic exchange resins also, cholesterol can alter the other drug absorption. Sometimes we can see that tricyclic antidepressants, when we are given with dicumarol, the activity may be motility of the gastrointestinal motility will be increased. And the anticholinergic agents given with levodopa, the motility will be reduced. This leads to the drug stay in the gastrointestinal time will be reduced or may be increased. Both are leads to toxicity only or maybe loss of therapeutic effect. Next, the induction or inhibition of drug transport proteins. So digoxin bind well with P-glycoprotein, and thereby it won't available for P-glycoproteins are won't available for binding with another drug. And malabsorption because of early start when we are going to take for it is actually a potent inhibitor of lipase enzyme in gastric as well as in pancreatic area. But this when we are going to take this early start, another drugs absorption will be affected. Next, in distribution, what are the drug interactions can happen? First, mostly we can see that acidic drugs binds to albumin. Basic drugs binds to alpha-1 acid glycoproteins. So the drug binding also, when we are going to give the pH of the drug also very important, where it is going to bind. Suppose warfarin is given, warfarin is it is a highly protein bound drug, so it will be there along with will bind with albumin and it stay long time in the body. So when we are going to administer another drug which is interacting with warfarin, then a replacement or maybe increasing the warfarin concentration may take place. So either it leads to toxicity or it leads to therapeutic failure. So when we are going to give these drugs, we have to carefully monitor. So that is termed as therapeutic drug monitoring. So we have to measure the drug concentration in the plasma. And most of the time, drug displacement interactions are common in distribution mechanism. Next, metabolism. Here, the most of the drug interactions happen in our liver metabolism. So there are two types of metabolism can take place. First one is phase 1 reactions, another one is phase 2 reactions. Phase 1 reactions are mostly alter the drugs by oxidation, hydrolysis, and reduction. By the group of enzyme, it is called as a cytochrome P450 enzymes. There are several subclasses of enzymes are there in phase 1. That is a CYP1A1, CYP1A2, CYP2C9, like that. Several enzymes are there. Is there any inhibited in inhibition by another drug? Some drugs may be inhibitor, some drug may be a inducer. So these enzymes are induced or inhibited, it will alter the action of another drug or metabolism of the another drug. And the phase 2 reactions, mostly we can see that it is conjugation type, mainly glucuronic acid conversion method. So the ultimate aim of metabolism in our body is converting the drug. It is called as biotransformation, converting the drug to eliminate from our body. So free drug produces the action and the altered drug will be eliminated in the urine or as well as gastric through gastric tract. Here the classic examples with enzyme inducers as well as inhibitors. Here we can see that CYP1A2 is actually the substrate drug is theophylline. It is metabolized mainly by CYP1A2. When we are going to give along with another drug such as fluoroquinolone antibiotics, such as ciprofloxacin or something we are going to give, definitely it will inhibit the enzyme and it leads to theophylline toxicity because the enzyme level may be decreased. So free drug concentration automatically leads to drug toxicity. So another example we can see that some induces just we can see that phenytoin is a phenytoin or omeprazole proton pump inhibitor is very commonly prescribed, and when we are going to take omeprazole, this induces the enzyme, so enzyme level will be increased. So when we are going to take theophylline or substrate drugs, definitely the drug concentration won't be available. The drug is not sufficient for the patient. So this is because excessive metabolism. So another classical example like CYP2C9 warfarin with isoniazid and CYP2C19 lansoprazole with carbamazepine or cimetidine. And here we can see that fluoxetine or haloperidol with dexamethasone or amiodarone. There are several drug classes as a substrate or maybe a inducer or maybe a inhibitor. So because of this complex metabolic pathway, the drug interaction is very common with many drugs. And we can see that mostly these anti-tubercular drugs, antiretroviral drugs, patients with immunocompromised, they are going to take immunomodulators. Definitely there are chances are there for drug interactions. So we have to monitor closely these patients for drug-drug interactions. And here we can see that rifampicin, when we are given with the oral contraceptive drugs, then it leads to therapeutic failure of contraceptive pills. So there are several classical examples in metabolism-related drug interactions. Mostly in elimination, the drug interaction takes place because of changes in urinary pH. And the elimination of that particular pH is, if it is increased or decreased, the alter the drug pH also. So it may leads to elimination, reduced elimination, or maybe increased elimination of the particular drug. So next one is change in active renal tubular excretion or a renal blood flow or a biliary excretion. This or the actually renal blood flow is responsible for formation of the urine. So is there alteration? There is definitely the increased secretion of urine or maybe decreased secretion of urine. It also leads to accumulation of the drug or maybe increased elimination of the drug. So biliary excretion also very important. And drug transporter proteins, altered mechanism of binding of drugs to drug transporters also leads to elimination may be altered. Next, pharmacokinetic interactions. Already we discussed this actually antagonistic interactions. So we can see that classical examples, beta 2 receptor agonist, salbutamol is given. The same time when we are going to give one beta antagonist, then definitely there is a contraindication. So it leads to drug interactions. And opioid antagonists such as naloxone is taken with benzodiazepine. Antagonists such as flumazenil, it causes that is actually used as an antidote also sometimes. So drug interactions are more chances with this opioid antagonists. And additive or synergetic effect we can see with the CNS depressant drugs along with alcohol and anti-arrhythmic drugs with diuretics. So it causes ventricular arrhythmia. The next one is serotonin syndrome. We can see that two serotonergic drugs taken, then it alters the another drug and leads to adverse drug reactions such as confusion, disorientation, abnormal movement, and exaggerated reflexes, fever, sweating, diarrhea. Several ADR can happen with these two drugs. And drugs or neurotransmitter uptake interaction. Here we can see that monoamine oxidase inhibitors reduced breakdown of noradrenaline in the adrenergic nerve endings. It leads to sometimes when they are going to take with amine class of drugs, amphetamine, tyramine, this leads to hypertensive crisis. Next, drug food interactions. Mostly this is because of this altered inhibition of this enzyme. Main enzyme in our liver is CYP3A4 or CYP3A5. 50% of the drugs metabolized by these enzymes. And calcium-rich foods, when taken with antibiotics, definitely there is complex formation. That also leads to drug interaction. And fermented food with monoamino oxidase inhibitors, vitamin K-rich food with warfarin, alcohol with CNS drugs, all are leads to reduced absorption of these drugs mainly, or maybe altered metabolism of the drugs. Drug herbal products. Here we can see that commonly most of the time we can see that garlic is actually having most of the herbal remedy, but it is interacting with many drugs. And the secondary antiviral drug, chlorpropamide, ibuprofen, this leads to reduced effect or maybe increase the effect of these drugs, leads to hypoglycemia or bleeding. So it alters most of the times. We can see that the herbal formulations, what it consists of, it is actually not predictable how the herbal will interact with the drug, and it maybe leads to adverse drug reactions. But most of the time the adverse drug reactions, when we are going to review, the patient may take any other herbal medicines. So most of the time we can see the outcomes, it is leads to loss of therapeutic effect of one particular drug, or maybe it leads to toxicity of the drug, or sometimes unexpected increase in pharmacological activity of the drug. So when prescriber giving the drugs, sometimes it is a wanted effect. It is called as beneficial effect. We can see mostly with drugs with additive effect or maybe a synergetic effect. It is needed. It is called as additive or potentiation action. Because sometimes we can see that patients with a higher blood pressure, we need to control the blood pressure in such a rapid way. So we have to give two drugs can be given, two hypertensive drugs can be given. It may be an additive effect, but it is a wanted effect. The same way, when we are going to control the blood sugar, we have to give insulin as well as along with the oral hypoglycemic agent. So we have to bring down the sugar level immediately. So we have to go with the additive effect. That is wanted drug interaction effect. But most of the time we are not we cannot expect all our wanted effect. So all unwanted effects are classified as adverse drug reactions. So how to reduce the risk of drug interactions? Patients, we have to see the patient risk factors. So age, medical condition, diet, smoking or alcohol usage. That also we have to take it as a note to find out that it will interact with the drugs when they are going to take. So accurate patient drug history is required. So we can collect all the information about the patient, their previous condition, as well as the current medical condition and the current medication what they are going to take, and already what are the drugs they take, and everything we have to collect in the accurate patient history only. And knowledge of drug action is essential in assessing the drug interactions, because we have to update the drug, what are the drugs, what are the class of drugs, how it will act. We have to update always. And when possible, we have to use therapeutic alternative instead of the drugs that can interact with another drug. So avoid complex therapeutic regimens and number of drugs. So when we are prescribing, the prescriber giving more number of drugs, it leads to drug interactions. So reducing and most accurate drug can be given for particular sign and symptom. And we have to always educate the patient about their illness and the benefit of taking these drugs and what is the risk associated with the drug. We have to educate the patient through patient counseling. So some of the websites I'm showing here, clinical pharmacists already they know about these drug websites, drug interaction checking website. This is Medscape. Here we can see that drug interaction checker is here. So when we are, next option is actually when I'm going to select the drug interaction checker, the next page will open like this. So just I checked it here, 4 drugs, warfarin, propranolol, pantoprazole and aspirin. So it is showing that 4 interactions are the possible drug interactions can be with this aspirin, warfarin, propranolol, as well as pantoprazole. So mostly we can see that propranolol with warfarin, aspirin with propranolol, or warfarin with aspirin. This is another website, Made India. Here we can see that we can give 2 drugs, drug 1 and drug 2, and we can check the drug interaction. This one is prescription list, rxlist.com. Here also we can give a list of drugs and we can find the possible drug interactions. So very briefly, I took this session, and thank you for giving me the opportunity, and keep educating yourself for safe and successful practicing pharmacy. Thank you.
Thank you, Dr. Krishnakumar. That was very elaborate and very nice explanation for the drug interactions. And the drug interaction checker was very interesting. I hope many of our fellow pharmacists visit and use it. So thank you very much. Now I think it's time for Sami to conduct the quiz. Yeah.
Right. Thank you, Dr. Krishnakumar and Dr. Heber for this excellent presentation. And we have received actually a very good feedback. So now we have 2,800 people watching the webinar live, which is an excellent number. So thank you everyone, all the attendees for joining in. And out of these 2,800 attendees that we have, in fact, 15% of them, so about 300 of you have participated in the quiz that we had rolled out 2 days back. So yeah, out of 300 participants who answered, approximately I think 20% of them got the answers right, and these are the 10 people who got were the first ones to give the correct answers. So congratulations to each and every one of you from IPA and from Servier, Asha Rego, Ansi Varghese, Shubham Yadav, Shailesh Avadia, Joyce, Isaac, Shilpa Kamath, Priti Rathore, Idnath Biswas, Rakesh Kumar, and Anupam Dubey. So congratulations to each one of you. And tomorrow's quiz is also going to be shared with you by end of day or by tomorrow morning. So please make sure that you participate in the quiz as well. So congratulations once again to the participants, and keep participating in the quiz. It will be there for day 2 as well as day 3. On this note, I think we're already running behind time. So what we can do now is we can hand over to Mrs. Manjiri to take the Q&A and then share the thank you note for the speakers.
Thank you, Samir. The quiz was very interesting, and we have participants from all across the country winning the quiz. And I don't see anybody from Mumbai yet, so maybe tomorrow. Yeah. So thank you again to both the speakers for very interesting presentations, and you made the concept of drug interaction and medication is very clear theoretically, and gave very good examples which are relevant to our day-to-day practice. One question here, I mean, there are many questions, but depending on the time we are taking the questions. One question to Mr. Heber, Professor Heber. See the prescription errors. How can I control the prescription errors? Basically, not all the prescriptions are computerized, and the doctor's handwriting in the prescription is challenging at times. So if I can't read it, if it is not legible, then what can I do when I receive such prescription? What shall I do to avoid, to ensure that I'm not doing any error here? So how can I control the prescription error when the prescription is not very clear or the handwriting is not very legible?
Yeah, thank you for that question. Actually, there are quite a lot such prescriptions that may not be legible most of the times.
Yeah.
That's unfortunate.
Unfortunately, yeah.
Unfortunate. But having said that, we can't afford to that. We can't commit mistakes blaming the illegible handwriting. So we should take some necessary steps to sort that out. If possible, you can contact the doctor.
Yeah.
Or you can talk to the patient. You can talk to the patient and find out what's wrong with the patient, what's the diagnosis, and you can try sorting out the possible treatments. And somehow we need to make some effort to find out the correct drug. And still, if you are not sure, just don't dispense, just make sure and then dispense. That's what I would suggest, yeah, rather than committing a mistake.
Yes, so this is a very common problem, faced by hospital. I mean, especially community pharmacists, as well as in hospitals, it happens. But in hospitals, at least they have access to the doctor, easier access.
Correct.
Than in the community. So these are the real issues. There is one more question about drug-food interactions and drug-herbal interactions. If you can give some examples and if you can differentiate. I mean, I know differentiation is pretty clear, the drug-food interaction and the drug-herb interaction. So if you want to...
Actually, drug-food interactions, mostly we can see that it is involved, this absorption of the one drug is altered or maybe reduced. The classical example is when we are going to take tetracycline along with the food, the tetracycline availability or maybe absorption may be reduced. So the antibiotic required for the action will be less. So it won't be available. So we have to increase the dose of tetracycline. That leads to failure of antibiotic therapy. So this is called as classical example for drug-food interactions. Sometimes milk containing products that will bind with these antibiotics and forms complex that also reduce the absorption of the drugs. And drug herbal interactions, we can see that in herbal, what are the chemical constituent, what it is present to be content, we do not know much about that. Okay. So we can see that, for example, garlic or ginger, when we are going to take along with warfarin, there is an increased risk of bleeding. This is one example. Because when we are going to take herbal medicine along with allopathic medication, so definitely there is a chance for interaction because the chemical components of these herbal drugs. So when we are going to take, we have to inform to the PCCN as well as the pharmacist, because pharmacist may know that what are the chemical constituents present in these herbal medicines, or maybe he will give a warning, we should not take the herbal medicine like that. So this is two different aspects. But sometimes herbal drugs like ginkgo biloba, maybe they are going to take say St. John's wort for their multiple purpose, the patients they will take. But in India, I think most of the time, this homeopathic medications actually it is commonly practiced, because the people they are taking for their diabetes as well as for hypertension, this and all, they will use these homeopathic medicines. Sometimes they will use these herbal medicines. That also there are chances are there for drug interactions. So
So
we
it's
have to avoid.
still a lot of research needs to be done, I think, on the drug
Yes,
herb
but definitely it
interactions.
is needed.
Yeah, I have come across some interactions between phenytoin and Shankapushpi and so on, but I think still we have limited knowledge
Yeah,
about.
drug food and drug herbal
Yeah,
interactions.
Mr. Heber, Professor Heber, you want to add anything into this, especially the drug herb interactions? Any thoughts?
Um, I'm not much familiar with the drug herbal interactions.
Okay.
Yeah, but I think what Dr. Krishnakumar said would suffice.
Right. Are there any, there is one question. Are there any particular recommendations for insulin dosage and insulin storage?
Is it for me or?
Yeah.
Yeah, it is both of we can answer, no problem. Actually, definitely there is actually recommendation is there, and guidelines also we have to follow, and storage we have to follow as per the instruction. What is the type of insulin we are going to use? That is very important, and the dose also very important, because if we are going to miss the dose or if the dose is altered, that leads to patient either it is a hyperglycemia or maybe a hypoglycemia. So when we are going to use insulin, very carefully we have to use that. And when they are going to use the dose self-medicate, they are administering selfly. Okay, most of the time insulin injections are given for the patients. They can inject themselves. That time we have to advise the patient, or we have to educate the patient properly. This is mainly by pharmacists. They have to give this instruction to the patient.
Yeah. Okay. Any information on the multiple drugs which are right now used in moderate to severe cases of COVID? Any drug interactions known? I mean, it's like many drugs are used depending on the patient's condition. If the cytokine
Actually,
storm is
definitely there
starting,
is.
so
Definitely, madam. Actually, now most of the people, when it is in the starting stage in COVID pandemic, so hydroxychloroquine, actually, most of the time they told that it is a life-saving drug like that. Okay, it may be a life-saving drug, and we are not going to discuss about that. But the ADR related to that particular drug is very important. So it causes a severe QT prolongation, and as well as it leads to cardiac toxicity as well as other side effects also. So we have to think about that, and we have to use the drugs. Also, there are several antiviral drugs. Most of the time it is trial and error type only. Okay, so we
yeah.
cannot say that one particular drug is effective for COVID. Maybe recent updates yesterday update that actually Russia released its first vaccine. So that would be
Yeah. Still,
good milestone achieved in
it's an
this treatment.
evolving science. So we are trying different regimen for treating the COVID. And in
Yes.
this, so thank you very much, Dr.
Definitely, there is a drug interaction as well as adverse drug reactions involved with any medication use. So we have to monitor the patient. But when we are going to see the cases, there is no such report. I didn't see that. But sometimes the reports are there. That maybe more research is needed for that specifically. But when we are going to see that a disease or a drug-related problem, this disease is actually we have to focus on disease only. So they are going to use the drugs because of the disease and
Yeah.
its severity.
So anything you want to add, Ms. Professor Heber?
Yeah, actually, this new drug remdesivir.
Yes.
We do not know much information on this remdesivir, but recently FDA has advised not to use with hydroxychloroquine because many hospital settings they use hydroxychloroquine even today, and remdesivir has rushed in. But at the same time, we need to be aware that remdesivir is not supposed to be used along with chloroquine or hydroxychloroquine. That's one update. Yeah.
And to add
There is,
that, actually, yeah, madam, that actually we have to add a point that actually most of the time all treatment protocols under clinical trial. Okay.
yes. So I have seen, I've studied the protocols given by ICMR.
Yes.
And so, I mean, as per the category of the patient, mild, moderate, or severe.
Yes, ma'am.
So, yeah. So hydroxychloroquine not to be, yeah, that's fine. Remdesivir. So there's also favipiravir now. So, so many drugs are coming in. So
Yes.
it is a very dynamic science, and every day the things are changing. So
Yes.
thank you very much for clarifying giving the answers to satisfactorily for all these questions. There are plenty of more questions. Maybe Sami will email it to you, the Excel sheet of all the questions. So it will be interesting for you all to you both to go through the questions and the feedback on your lectures. So excellent lectures. Thank you, Dr. Krishnakumar. Thank you, Professor Heber, for giving an excellent talk. And thank you all. Thank you all the pharmacists. Thank you all the supply chain professionals, all the healthcare professionals for joining with us today. And thank you, Mr. Raja Reddy, and thank you, Mr. Sami, for structuring the program so well, and the entire team of Servier, and also conducting interesting quiz. And we hope to see you tomorrow as well as day after tomorrow. So stay tuned in and connect with us tomorrow at 3 p.m. Thank you again. Stay safe, stay well. Thank you.
Thank you so much.